Well, welcome. My name is Erica Shear. I am a psychologist at the VA Puget Sound Healthcare System, and my colleague and I, Shiloh Jordan, at the VA Pacific Islands Healthcare System, are so excited to be speaking for you on behalf of ABCT today on the strategies for effective telesupervision. So we've got quite a big list of topics today, and we will do our best to talk about these in an expedient manner, but please, you'll see our emails at the end of the slide deck, so please feel free to reach out if there's additional questions or if you would like to do any consultation. So we're going to very briefly talk about the rationale for telesupervision, but then the majority of our presentation today, we're going to talk about these next four topics. So we want to talk about access and communication, identify strategies to maintain appropriate oversight, identify strategies to scaffold learning experiences, and then last but not least, discuss how we can support our staff, our trainees, our supervisors as we're making this transition. All right, so let's talk briefly about the case for telesupervision. So as you may be aware, the extant literature on telemental health shows that it produces results comparable to in-person care, and thus it's reasonable to expect that telesupervision should parallel this process, and that the quality of supervision should not be diminished because of a shift in platform or setting. That said, it is necessary to have a thoughtful approach to how we provide telesupervision in order for it to be successful, and that's what we want to be discussing today. Of course, right now, in light of recent events with COVID-19, telesupervision is now essential in order for us to continue to uphold training and safety of public health. So let's talk briefly about APA and the Commission on Accreditation's stance on telesupervision. So during non-pandemic times, as defined by APA in their Standards of Accreditation, for interns, telesupervision can account for up to half of the minimum requirement. So that's up to 1 hour of their 2 weekly individual hour requirement, and up to half of the minimum total, which would be 2 hours. Mirroring this for postdoctoral residents, telesupervision may not account for more than half of the minimum requirement as well. Now, during pandemic times, that requirement has shifted in that there is a temporary expansion so that telesupervision can encompass all supervision during this time. So both Shiloh and I are working within the VA system where in non-pandemic times, telesupervision has not been permissible unless you have a waiver. And Dr. Jordan is at the VA Pacific Islands Healthcare System, which is one of 2 sites that does have a waiver to provide telesupervision. And she and I happened to meet at a training and just happened to coincide and our paths cross, and we were able to share our passions for telesupervision and desire to examine this, which led to this evidence-based practice project at VA Pacific Islands, where we were able to offer the trainees there a questionnaire assessing their experience of telesupervision. So the VA Pacific Islands has been utilizing telesupervision since 2014, with telesupervisors being located as far away as American Samoa and Guam. And considering that this is across the international date line, this is quite significant. And these telesupervisors are supervising trainees that are located at the main facility on Oahu. And those trainees are providing telehealth to veterans in Saipan, American Samoa, Guam, and all the other Hawaiian islands. So you can kind of envision what this looks like. Trainees participate in both in-person and telesupervision rotations concurrently, and their patient care mirrors the platform of supervision. So if they're receiving telesupervision, the telesupervisor is supervising patients being seen via telehealth. So as I mentioned, we were able to collaborate on this evidence-based practice project. And what we found from these questionnaires, which included quantitative items, the Supervisory Working Alliance inventory, and qualitative items, was that overall, trainees found telesupervision and in-person supervision to be equitable experiences. And it was very interesting to find that despite a small sample, there was a significant difference in rapport on the Supervisory Working Alliance inventory, with telesupervision being higher. And we hypothesized that this is really not so much about the modality, but about the supervisor, mirroring patient care, that good care is good care. And Dr. Shiloh Jordan, knowing her telesupervisor, being able to advocate and know that this was a very good experience. So we were also able to identify some challenges and benefits to telesupervision, some components of successful supervision as well. So you'll see here we have supervisor attributes on flexibility, willingness, and experience, being experience in telemental health. Trainee attributes, mirroring those, also flexibility, willingness, and the developmental level. And so one hypothesis from this project is that for a trainee who may be beginning the rotation with perhaps not as much experience, that it would be important to really scaffold that experience and ensure that there is adequate oversight and access to supervisory support to make this successful. And then, of course, the logistical components. So needing space and the technology, needing to be able to access supervisory support, and needing to be able to have time to develop comfort with the technology. Okay, so bottom line, what we found is that good supervision is good supervision. So implementing telesupervision doesn't mean that the quality of supervision should be lowered, and it doesn't alter any expectations of the trainee, the supervisor, or the training program at large. So in order to be successful, we need to make sure that we are thoughtfully adapting traditional in-person supervision methods so that we can continue to assist trainees in developing needed competencies, completing required training requirements, all while maintaining patient safety and quality care. So at this point, I want to talk more about the how, and we'll start with talking about how to foster access and communication. So what we mean by this is the who, the how, and the when of supervision. You'll see in this slide that there's a sample supervisor coverage grid, and we just put this here as a potential snapshot for you to consider. So just as in the case of in-person supervision, trainees must have appropriate levels of access to their telesupervisors. And this coverage plan should be detailed, it should be overtly discussed, with the idea that particularly in pandemic times where you may have trainees who are teleworking, who may be rather isolated themselves, they won't be able to physically seek out a supervisor. And should an emergent concern arise, they might be perhaps scrambling in that moment. And so having something like this that is very explicit, detailed, very clear could be very helpful. So ideally, this coverage plan is multi-layered with the contact methods for each supervisor clearly identified. And you'll see here we have this primary supervisor, the backup, as well as at the bottom, if either of these options aren't available, we have a couple other options. So this might be a training director or perhaps another colleague on the team. So when we're talking about how identifying how trainees will access their supervisors, it may be helpful to think about this in terms of the different types of supervision opportunities. So of course we've got the regularly occurring supervision, but there's also the need for on-the-spot supervision for emergent concerns, as well as unscheduled or ad hoc supervision for non-emergent concerns. Regularly occurring supervision may be the one that typically comes to our mind when we're thinking about the logistics of telesupervision. It should be scheduled and prepared for in the same manner as in-person supervision. And the thought here is that doing telesupervision in the same modality as patient care will help the trainee really develop the skills and competencies for navigating that system. So if it's over the video teleconferencing modality, it's another opportunity for trainees to work on proficiency and increasing their skill set. And what's interesting is there is some evidence to suggest that the video-based modality has some benefits. So disclosure, there's some interesting data on that. And there's also some interesting literature on video-based modalities having a greater emphasis or requiring a greater emphasis on verbal aspects of communication, which we can surmise would facilitate improved communication and supervision processes. So those are some other pieces to consider. Then for on-the-spot and ad hoc supervision, we want to make sure that the trainee has the same level of access to supervision for emergent and non-emergent needs. So a supervisor should be available and capable to join a session in a timely manner, which means that supervisors need to know how they would do so. Instead of needing to or trying to problem solve technology in the moment, this should be practiced with the trainee and should be something that the supervisor feels comfortable being able to do. So some examples of ways to be readily available include having some kind of instant messaging option open and visible, having a cell phone on with the screen up and in view so that alerts are kind of visible on the screen, and perhaps talking with the trainee about languaging around alerts so that the supervisor is aware when they need to attend and attend with urgency. Particularly right now, given all of the communications and electronic communications that are flying around, it might be important to think about how the trainee's communications to the supervisor won't get lost in the shuffle. And just an additional note that a trainee sending an email or voicemail that's checked every few hours is not being readily available. You know, that might suffice for a daily check-in or something like that, but really won't encompass or address the need for on-the-spot and ad hoc supervision. Identifying when to access supervision. This is something that may merit, what am I trying to say here, a second glance or a review. So given that this abrupt shift to telesupervision and potentially teleworking on such a large level scale, given the recency of it, it might be an appropriate time to reassess those needs, those availabilities, those expectations, and be very clear on that. So these needs must be clearly discussed, and that could be the supervisor needing to know exactly when trainees have scheduled patients and what the trainees' days look like when they're in didactics or perhaps some kind of research time versus clinical time. Also, trainees being informed of supervisor availability, and we talked about the backup plan already. And then last but not least, the expectations with regard to frequency and method of check-in. So as I alluded to in the previous slide, knowing the best methods for trainee and supervisor to be able to engage in not just checking in, but making demands for scheduled or unscheduled and ad hoc supervision as well. Okay, at this point I'm going to transition to Shiloh.
Hi. One of the major areas that can bring up anxiety for supervisors as well as training directors is how we can maintain appropriate oversight of virtual trainees or provision of telesupervision. So in looking at, really looking at the amount of oversight is based on the trainee competency. And this would be the same as for in-person as well as telesupervision, but telesupervision lends itself to taking an even closer look to what level of oversight we're providing to the trainee. And so it can span from everything from in the room to being readily available. And in the room, an in-person supervision would be the ability to physically step into the room, do live observation or co-therapy. And this is mirrored within the telesupervision and provision of telehealth realm, with supervisors being able to either be present for the duration of the session or to step into the session as needed or conduct co-therapy over the video platform with the trainee. As Erica mentioned, we are both in the VA system, and the VA has a specific language around this of graduated levels of responsibility, and in which we're thinking of what is the level of responsibility that makes sense given the trainee's developmental level. And developmental level is really where they're at within the competencies, not necessarily their years of experience, as those don't necessarily equate one to the other. Now, this brings up the point of assessing and adjusting the intensity of oversight according to then the needs of the trainee. So it can be a good idea prior to telesupervision or engagement in telehealth that some sort of a baseline competency assessment is done to understand the development need of the trainee, and so that we don't just assume that where they're at, whether they're at the intern level, practicum level, or postdoctoral level, matches what their actual skill level is, and skill level specifically for the telehealth platform as well. And so at the onset of the telesupervision or telehealth experience, supervisors may need to adjust the intensity and type of oversight according to the demonstrated competencies of the trainee. And we go back then to that graduate level of responsibility, or being in the room versus available, and is that matching the developmental need of the trainee rather than us assuming where that trainee is at, and particularly important within the virtual realm. Throughout the training, throughout the telesupervision and telehealth experience, supervisors want to then continue to monitor the competency development of the trainee and adjust the intensity and oversight needed according to where that competency development is. Is that in the realm of psych assessment and testing versus provision of therapy versus maybe some interdisciplinary consultation interactions? And be willing to step back to a higher level of oversight with increased frequency of feedback as needed. This is not unique to telesupervision in this idea that it is really operating in a flexible model of us stepping back oversight as needed according to the developmental need of the trainee, and just being thoughtful in application within the provision of telesupervision. This can be particularly important if the transition to telesupervision is the middle of the training year, as it has been for many in the midst of the pandemic. Another element that's incredibly important when looking at quality telesupervision is maintaining direct observation of the trainee. This is in alignment with accreditation standards and also within the what we know about quality supervision and how much richness is gained when we directly observe the work of our trainees. This can be done by either dialing into video sessions, and that can include co-facilitating individual and group sessions, or joining as an observer and turning off your camera. As well, three-way phone calls with the patient trainee supervisor. So this is when care is done over the telephone, which based on the availability of technology for some of our patients or clients, that can be another important way for them to access care, or recording the sessions to be later reviewed by the supervisor. And so it would be important within your institution to really be looking at what are the policies or standard operating procedures and stakeholders that you would need to consult with in order to ensure that you have all privacy concerns addressed and good maintenance of records addressed in recording those sessions and saving them securely. And the great thing about that process is a supervisor and trainee can access them together, can review them at separate times, or within telesupervision, pull up that digital file and be listening to it or watching it together as well. And it really, if we look at good in-person supervision as well as telesupervision, we want to continue to scaffold to enable training in the competencies. So we want to facilitate the development of profession-wide competencies in the virtual environment, and not view provision of telesupervision as less oversight or as a lowering of our standards or a lowering of the competencies that we're training to. However, we may need to overtly translate for supervisors and our trainees how to effectively meet the competencies or train to the competencies through a modality that's a little bit different than maybe what they're used to in either their own standard of patient or their own provision of patient care, or even their historical engagement in training. So some examples are, if a trainee is having difficulty with the competency related to consultation and interpersonal interdisciplinary skill, they may benefit from us assisting them in identifying ways in which they can effectively develop and exhibit this competency in a virtual manner. So how does this look when your activity when you're not in an in-person meeting, but you're virtually? Is it easier to be a lot more quiet? How would you effectively have your professional voice in this setting? That may look different than when you're in person. And then also looking at how are we upholding ethical and legal standards within our telehealth documentation, appropriate informed consent, demonstration of knowledge related to ethical concerns specific to telehealth. And so there are not different competencies we're training to, but the way in which we ensure meeting these competencies and training to the competencies needs to take into account the context of the learning environment, which includes the provision of patient care over telehealth, as well as engagement in telesupervision. This then scaffolding and oversight then means we also need to uphold the provision of feedback. So as with in-person supervision, telesupervisors need to be intentional and consistent in providing timely and meaningful feedback to the trainees. This is no different from in-person supervision. And when we look at the work of Fallender and Shafransky on knowing the importance of evaluative feedback at each supervision session, and being consistent in that feedback over telesupervision ensures that trainee knows where they stand, what they need to work on, what they need to keep doing, and ensures a good feedback loop with the supervisor and trainee. The feedback mechanism for trainees and telesupervisors needs to be explicated. So in really looking at how am I going to give you feedback and how would I like you to respond to me. We're not going to have an ability to drop by and poke our head in the door, knock on your door, or drop by your office. So we need to say like email, instant messaging. What is the way that you're most comfortable receiving feedback? What's the easiest way for you to digest it? What's the timeline for that feedback, since it will be all exchanged within the virtual realm. And training programs should provide electronic means and associated prompts to assist supervisors in maintaining appropriate documentation of supervision sessions, completion of relevant training programs, supervisory contracts, and other record management in accordance with training program requirements. So ensuring that supervisors are also having all those things that we do within in-person supervision also on their radar for telesupervision. Sometimes there's this thought that if we do it virtually, it's radically different or changed, instead of ensuring that that same standard is upheld even if the platform looks different. And one thing that is a stressful process for all involved is when we experience a competency concern or a remediation plan or probation experience that as a result. So we want to look at really continuing to maintain the proper level of oversight and feedback loop that allows us to initiate remediation plans as needed. And some things that occur within this plan would be in increasing the scaffolding of learning and in increasing the level of oversight and the opportunities for oversight. So this would include increasing direct live observation over the platform and including moving to more co-therapy versus independent therapy. Appropriately scaffolding the direct experience to the developmental need would really be looking at what is the provision of patient care that's occurring and what adjustments do we need to make. Identifying specific barriers to effectively engage in the remediation plan. What is getting in the way of the supervisor maybe giving feedback more frequently or observing more frequently, whether it's time in their schedule, comfort with technology, recordings from the trainees that are given, and what is the barriers from the trainee side that are getting in the way? What is it that's whether it's platform issues, certain presenting concerns of clients, consistency and feedback, what do they view as their barriers? And then we want to identify specific ways competencies can be demonstrated within the virtual setting. So this can be really looking at how are we giving opportunity for the trainee to develop and demonstrate these competencies within the virtual realm. And it's really a translation of the in-person experience and training environment to the tele experience. And regularly meeting virtually to review the remediation plan. So just like we would for in-person, we want to regularly meet with the trainee to review how they're doing and what changes need to be made to the plan. Of utmost importance is supporting supervisors and trainees as they transition to telesupervision. Really having adequate time for supervisors to do their work and feeling supported in the work that they do is highly important. Providing dedicated time to adjust to telesupervision and incorporate access and oversight of an oversight recommendation. So supervisors just in the parallel process with the trainees may need time to adjust to a new way of engaging in training and in supervision. And so are we advocating within our leadership structure for them to have the appropriate time? Are we helping scaffold their learning experience as they're adjusting to how to provide telesupervision effectively? And are we asking what their kind of needs are developmentally in their own comfort in providing training and oversight within this realm? And that includes being able to appropriately access technology and the time to develop their comfort with the platform, as well as helping them to translate what does it mean to train to this competency in person versus tele. And how do we create that crosswalk in understanding of how we are training to the same competencies, but through a different modality. We want to encourage them to also exercise their good judgment, that they want to, that they need to be able to operate in good judgment of their licenses, of awareness of ethical and legal practices, and that enables them to then have good comfort in the supervision that they're providing versus just being told, okay, we're doing it this way now, and they don't have their questions answered or aware of the good of the ethical and legal knowledge that they need to have to do their own patient care effectively over telehealth, as well as the provision then of telesupervision. They may benefit from increased contact with the training director and colleagues for both provision of support, increasing consultation, and maintaining timely communication of feedback with trainee and the training program. This may include monthly meetings. This may include ways that they have time set aside to be able to meet with the training director, meet with their colleagues, additional time for supervision. And this is really to then lessen the learning curve for our supervisors, as telesupervision is a really new way of implementing an essential skill of good supervision within our field. It also is important to consider the ideal supervisor characteristics when looking at supervisors for this role. Not all good psychologists are necessarily good supervisors, and not all supervisors are necessarily a good fit for telesupervision. If supervisors that are not very responsive to email, instant message, text, phone calls, are a little harder to get in touch with, they are not ideal for implementing supervision within this type of platform. All right, so we want to make sure we're also providing the necessary support to trainees. The same process at the start of a rotation applies for both formats of supervision, whether you're in person or telesupervision. While the telesupervision trainee may need more tangible guidance as they are learning a new system. So they may need more of the how-tos laid out a little bit, because the same realm of just turning to your neighbor or knocking on the door of the supervisor may not readily be available in the same way. So giving them the opportunity to have intentional practice to gain comfort and feedback for telehealth, being able to do a practice telehealth session with their supervisor and a role play before doing it with a live patient or client, observing their supervisor engage in telehealth sessions, co-facilitating individual group telehealth sessions with their supervisor or another psychologist, and really getting feedback from the supervisor on everything from their, I think it's an extension of their stimulus value, their background setting, their camera angle, their facial expressions, their tone, hand gestures, being very aware of how they come across in this platform and what is their stimulus value that may need to be adjusted within this platform. Within the provision of telehealth and telesupervision, the trainee also must know the emergency procedures that are really specific to telehealth. And what is the expectation for communication with supervisors, frequency, timeliness for emergent and non-emergent issues? I think this is good practice, whether it's in person or telesupervision. But again, the distance, physical distance means that we need to just maybe more explicitly lay out for both parties. Also, how to record sessions. How are they going to be able to have live observation provided? And what is the best way to gain access to supervision between scheduled sessions? And this really overlaps with what Erica was talking about earlier in ensuring good access to the supervisors. So in summary, the implementation of successful telesupervision includes the thoughtful adaptation of traditional supervision methods to ensure that needed competencies are being developed, training requirements and expectations are being met, patient safety and quality care is maintained, and that the shift in platform should not result in a shift in quality or expectations. This is not a lowering of quality or a lowering of expectations, but a looking at how this translates within the telehealth and telesupervision realm. Telesupervision success may require additional support from the training program and explicit guidance regarding access, oversight, and scaffolding. So really looking at that this is a learning curve for trainees and for supervisors, and then creating then the environment in which that learning curve can be lessened is highly important. We really want to thank you for your time today. We've left our contact information here. You can feel free to reach out to both of us or either one of us with any additional questions that you may have for us. And also want to be sure that you know how to find additional resources, as well as reach out to us for any membership questions or interest as well. Thank you again for your time today.